Welcome and thank you for joining us for the meeting of the New York City Health and Hospitals Finance Committee. Today's meeting is officially called to order. I would like to propose a motion to adopt the minutes of the Finance Committee meeting held on November 3rd, 2025.
So moved.
Okay, thank you. And I second. And Dr. Katz?
Yes.
Dr. Martone?
Yes.
And I vote yes, so the minutes are adopted. Next, we have one resolution for consideration. Mr. Hart, please read the resolution and proceed with the presentation.
Thank you. This is a resolution authorizing New York City Health and Hospitals Corporation to incur indebtedness in the maximum aggregate principal amount not to exceed $200 million for the retirement of certain outstanding bonds of Maimonides Medical Center in connection with the transfer of certain assets of Maimonides Health Resources, Inc. and its subsidiaries and affiliates to New York City Health and Hospitals Corporation. The background on this transaction, why we're here, in November 2025, the board unanimously voted to allow Health and Hospitals to enter into an affiliation and asset transfer agreement with Maimonides and to take appropriate actions to advance the contemplated transaction. The anticipated close for this transaction is March 31st of this year. Subsequent to that, in December, the board approved creation of two subsidiary public benefit corporations to hold the assets and liabilities of both Maimonides hospitals. The hospitals have existing bond debt, which was issued by Maimonides and must be defeased at or prior to the close. There are two reasons why we're not able to take this debt into the corporation as is. The first being that subsidiaries of Health and Hospitals cannot issue or hold debt, so we can't move it with the other assets into the two subsidiary corporations created for that purpose. And the Maimonides bonds cannot be brought into the parent H&H corporation because they conflict with the covenants of our existing H&H bonds. For some background on what this debt is, as I said, is existing debt issued by Maimonides. They estimate that the total that we'll need to defease these is approximately $166 million. We've asked for authorization up to 200 just to provide some flexibility, but we don't anticipate needing that entire amount. There are two bond series involved. The first, Series 2013 bonds. They're approximately $38 million outstanding with a final maturity of March 2032. These are Government National Mortgage Association-backed taxable revenue bonds that were issued by Maimonides to refund older Federal Housing Administration insured bonds that were issued by the Dormitory Authority of the State of New York on Maimonides' behalf. The bonds remain insured by the FHA mortgage, which does impose certain restrictions and requirements. This series of bonds is currently callable, meaning that it can be repaid or refunded now. There is also Series 2020 bonds, which have approximately $127 million outstanding with a final maturity date in August of 2048. These are also FHA insured mortgage hospital revenue bonds issued by DASNY. They are not currently callable. They become callable in August of 2027, but they can be defeased by funding an escrow account to pay the debt service through that point and then pay off the outstanding amount. Tom Tran will take you through our proposed approach to dealing with this debt.
Thank you, Linda. On the next page is our defeasing strategy here. It's really a two-step process that we're going to walk you through here. The first one is the short-term borrowing through an interim loan that we're planning to use to defease these outstanding bond debt. And the structure basically will be used under our subordinate, under our general bond resolutions. The term of the loan is really between what currently thinking is 18 to 24 months. And then the sub bullet there is contingent on the completion of Maimonides transaction is really important to highlight there. Again, what we are seeking for board approval is on the interim loan to use to defease this debt. And this loan will not go forward unless the Maimonides transaction will take place. And then the second step is, once we do the loan as well, the Maimonides transaction is closed, at some point in the future, we'll do a permanent financing to retire this interim loan. And the current thinking is that we would do the takeout or use this permanent financing at the time when we do our next new money financing. The current timeline that we're currently on, as you see there in the box, we did an RFP for the loan. We have selected the bank to do the loan. We're currently obviously here to seek for your approval on the committee and board approval for this month. And then the other thing that we're going to be doing is a asset evaluation for this particular month and finalize the bank document to prepare for closing in the end of March and on that April 1st deadline. The next page is really give you a summary of TD Bank, who we selected to do this loan. Again, in corporation and
Sorry, Tom. Did you just mention, I just want to make sure on the prior page you mentioned the tax exempt acquisition financing.
Oh, yes, okay. Yes, this would be currently contemplated as tax exempt acquisition financing to pick out these two debts. Yes, that's important point there. So on the next page, we just want to give you a little bit of background that, we, again, in consultation with our financial advisors and our bond counsel, we did issue an RFP for the $200 million, under a number of scenario, both different maturity, fixed rate, variable rate, tax exempt and taxable, possible structure there. TD Bank, their current rating, in the RFP, we received 4 responses, and we selected TD Bank based on the best rate and term. The current rating as listed there, the long-term deposit, short-term rating, as well as their outlook. One note here is TD Bank is currently providing the system letter of credit for the outstanding series 2008 B and C, and then serve as a remarketing agent for the series 2008 C and E variable rate bonds. In the proposal, this is sort of give you an indication of where the interest rate is for a 2-year term. The variable rate there, fully funded, tax exempt, is a 351. And then the fixed rate callable, which can be prepaid anytime, is at 321. We listed taxable there. It's a remote possibility, but we just want to give the board a range of interest rate there. Again, variable rate is a 444, and the prepayment fixed rate is at 406. On the next page is really what's our next step is. Obviously, the debt finance will continue to work with our financial advisor and bond counsel to finalize the financial plan and negotiate the term of the loan, finalizing the bank document. Additional requirement, again, as we mentioned, we're going to be doing the real estate appraisal of the minority assets so we can transfer to tax exempt acquisition financing. And then, of course, finalize the loan size and structure, and then work with DASNY and FHA to go through the diffusion process with various counsel there. And this is what we are seeking for board approval, which is only related to the interim loan financing not to exceed $200 million for this minority transaction.
Any questions or comments? Okay, great. So thank you. I think the one question I had, the use of proceeds for the loan is only for the defeasance of the debt, or can it be used for other purposes?
It would only be for the defeasance of the debt.
And I think you addressed the tax exempt question I was asking. Okay, great. Well, no other questions. I'd like to pose a vote for the approval of the resolution to bring to the full board. Right. Dr. Katz?
Yes.
Dr. Martone? Yes. And I vote yes, so the resolution is approved. Thank you.
Yes.
Next on the agenda, we have a financial update the team is going to go through. So I'll turn it to you, John, first.
Good morning. Thank you for your time. Yeah, the system, I think, from our review through the first quarter performing, as we would expect, it's stable. We closed December with 634 million, 20 days cash on hand. I think today we're a little bit over 550 million, so cash is fine. We missed the first quarter by about 1% or $55 million, and we'll go into the details here, but roughly that's splits out half is expenses, half is revenue. I think of the revenue shortfall, we think most of that is timing. We'll come back, but we have plans in terms of how to correct on the expenditure side as well. Interesting enough, like after years of seeing year to year actual patient care revenue increases in the $400 to $500 million range, maybe we've hit the plateau, right? I think the fruit is now up higher in the tree, and we're certainly there's more to get, but we are, and I think we forecasted this fairly accurately, is that things would start to flatten out for us. Our volumes, kind of year to year, down a little bit on inpatient, still up on outpatient, and when you compare it to pre-COVID, our volumes are still significantly higher, so especially as it relates to outpatient, which is up 17%. Strategic financial initiatives, I continue to be on target here. We've achieved 104 of the target of 472. So at the 1 quarter mark of the year, we feel pretty good about all of those various initiatives, and we'll go into a couple there. We're also keeping our eye on, next year and the out years and things that we need to do to further improve the financial stability of H&H as we look towards federal cuts and the like, but controlling average length of stay is a big initiative for us, and we have activities working with the hospitals to appropriately bring down length of stay where we can, which is obviously very challenging in a big safety net system, but we have programs underway there. We talked a little bit about, if not centralizing, but in putting in place best practice approaches to revenue cycle and streamlining and bringing some consistency in terms of how we approach rev cycle, really from end to end. And Margie can talk a little bit about that. And behavioral health has been an ongoing effort with us, and we've continued to make investments in behavioral health. The Centers of Excellence program has been helpful in terms of a revenue stream that we use every dollar from that effort. And we have a little bit more work to do there, but feeling pretty good about how we've managed to bring back beds and build programs in partnership with the Office of Mental Health.
John, before we go off the slide, I think it's worth dwelling as a board for a minute on your third bullet, because what I think is so interesting about your third bullet is that that's what a successful mission-driven system should do, right? It should push up the outpatient visits and decrease the inpatient visits. And part of the problem of how healthcare is financed in the US is that's a bad financial thing, which is why so many systems, create ways of, hospitalizing people who don't necessarily need to be hospitalized, because that's how you make the money. But that's exactly what you would want. You'd want your system over time to increase your outpatient visits and decrease your inpatient visits. And how ironic it is that because of that, our receipts are down by $40 million for doing the right thing and bringing out the right outcome. It's just a fascinating comment about healthcare in the US.
Yes. Yep. On cash, I think, as I said, we closed January at 500, forecasted at 450, and I think we're at 550 now. Anything else there, James? And then the next slide is just, these are the risks that we, follow every period that we meet with you. I would say most is unchanged. There's a couple of things to highlight. We were a little surprised on the essential plan. As we know, right, that was a big problem with HR 1, the federal bill. We're hopeful, right, that the state will continue with its plans to renew or continue the basic health plan that existed before. They have an application with CMS that will help preserve funding for what we call the EP 1 through 4 group. The EP 5 group would be excluded, and we still have to find, solutions for that. The surprise came is the state released its rates, and the premiums that they set for the essential plan were actually down year to year about 4%. That was a little bit of a surprise for us. And why that's so important is because, we are, primarily a value-based payment organization, and those dollars that flow to Health First and Metro Plus eventually flow downstream to us. So it's really a cut on the providers, that are represented by Health First and Metro Plus, giving our capitated financing arrangement. We've raised that with the state, and there's reasons I can understand why, they've set those rates at the highest part of the rate range. And I can understand why they may want to, bring that down a little bit, but at the same time, I think they should also increase the Medicaid rate so that they're a little bit more consistent, right? Because I think Medicaid, and Megan will show you a chart, Medicaid rates are set at the bottom of the range. So to find that balance, I think would be a good approach there. But
John, they released the essential plan rates, but not the Medicaid.
Yeah, they released the essential plan rates. The Medicaid rates, they've released those as well.
Okay.
And we'll go through a chart that kind of shows that we're losing money on the Medicaid, premium, and that's not just health and hospitals. I think we're seeing that throughout Metro Plus and Health First. So this rebalancing of the rate makes sense, right? Because that inequity there has incentives, and the market will chase, where the margin is. And I think to bring the essential plan and Medicaid rates somewhere closer to one another would be preferable for us, for sure. The average commercial rate, as we indicated last time, we've gotten approval for what we call year one, which is 2024 through 2025, and year two, this 2025 and 2026, both been approved by CMS. We've yet to see those dollars. We understand that the state is close to distributing them. And then on year three, which is the upcoming year, starting April, we are working to develop what is called the preprint. Every year you have to submit an application to CMS. And our goal is to release that through the state to CMS. We would like to shoot for mid-February for that, giving us enough time for an April 1 start date. We really very much are continuing to strive to make rates prospective. And when they're behind, and these are the large, dollar values associated with these transactions, it requires us to move cash around within our plan to accommodate that. But our goal has always been, let's try to be prospective with these rate adjustments.
So the year one ACR rates, we have not seen that come into our.
We have not seen those dollars yet. We understand that the state is close on, calculating, the value of the distributions to each one of the plans, right? Because that requires them to do some analysis. And Megan and our team has been working with Health First and Metro Plus to kind of triangulate on a set of numbers. And we've provided those to the state, just again, to kind of make sure we're all on the same page with the analysis. Because at the end, you have to reconcile to a year-end number. And you would, at this point, right, when we're talking about 2024 and 2025, those numbers are pretty well known. But yeah, we're hopeful, right, that those dollars will be released soon. Both years, actually. So, and the year three preprint shouldn't be a problem. It's really just, for the most part, a continuation. There may have to be some decisions that are made there, but certainly we're trying to do this in such a way it's hopefully just is a pro forma approval with CMS without asking them to make any sort of special accommodation there.
And then if we've got cleared year one and two, then three should be.
Yes, that's our hope.
On track then.
Yeah, on
time.
track, following, the rules that were laid out, by CMS, by the new administration, incorporating, we'll have to start to incorporate the ramp down to the Medicare rate, which I think starts in 28. CMS we've heard is working on clarifying regulations as it relates to state-directed payment, but we've, across the nation, but we've not seen any specifics there. But we've tended to try to be conservative with our estimates and try to anticipate what some of those decisions might be, but we won't know until, their final regs are released.
inner conversation seems to be that CMS is functioning the best with the health departments on the federal level, that they're not with the same kind of disruptiveness, that they seem to just be that, besets the FDA and the CDC, but the CMS seems to be, continuing as a professional organization. And the people who have met with Dr. Oz, who, because of his TV view, people were, very negative on, have said that he's been completely professional and seems focused on the task. So,
That's great.
that's, I mean, you never know, but the inner dialogue has been positive about CMS.
Yeah, I would say at the staff level, which tends to go from one administration to the next, we've always managed to, have a good relationship with the staff. And I would say the same, they're always trying to be helpful to us within the rules, right? They have rules and we try our best to follow those and accommodate them, where we can. So that's,
And the staffing has stayed pretty
staffing
constant.
it's the same group of people at the level that we deal with, which is good because these are very complicated transactions and that the knowledge that
And they have the history.
Yes.
That's not true at the CDC or FDA.
Yeah.
See, that's what people are noticing is that the CMS is continuing to operate as a professional organization with the knowledgeable people staying in place, not feeling like they need to leave, not being swayed by political, mandates, but just doing their job.
Yeah, that's correct. The MCO tax, again, I think we'll get greater clarity on this. The state with MCO tax was approved for 5 quarters, not the 9 quarters that they were initially looking for. I think we'll get more clarity on what does that mean for the overall Medicaid budget, because they had, I think, in the neighborhood of $1.1 billion in various provider increases tied to the MCO tax. So the state's gonna have to decide, if or how they're gonna backfill those 4 quarters that they otherwise had in the plan. And then we're looking forward to, the new mayor's first budget, and I'm sure there's a lot of work going into that at the moment. And then the governor releases her state of the state, and executive budget will be released, later this month, and look forward to reviewing that and working with both the city and the state in crafting their budgets. And then hopefully not, but we might be looking at another government shutdown January 30th, but we're keeping our eye on the progress of those discussions. So those are the risks we continue to follow, and we'll continue to report on them. I think we feel pretty good about them at this point, as good as we can, and we'll keep trying to find ways to mitigate those as they occur.
Okay. Thank you.
Questions?
Any questions?
Yeah.
Great, thank you.
I'll take you through our quarter 1 performance. So as John noted, we missed our mark by 1% or $55 million in the budget through September. About half of that, or a little less than half of that, is driven by our revenue. We're seeing that there is some timing to the patient care revenue to come in, and we're working towards achieving our target by the end of the year. Also in our revenue, we're seeing our risk pool is slightly behind. Some of that is due to a lower per member per month rate that Megan will take us through throughout this presentation. And other supplemental and grant revenues are also lagging behind for the quarter. Though we expect to meet those, we are seeing that we didn't get as much as we anticipated for Q1. On the expense side, we are exceeding our budget by almost $30 million, mainly driven by overtime spending in that staffing category and some on-model expense. And also in our discretionary, we're seeing overspending in medical and other supplies. On the next slide, we can get through more details into the revenue. So we're 1%. The breakdown is here. Inpatient and outpatient is behind, again, driven by the timing of receipts. And also we have some new and improved strategic initiative targets. Our length of stay reduction activity is ongoing and ramping up even through quarter 2. We're doing system-wide efforts, data-driven approaches to address some of these average length of stay areas and also continuing to expand in outpatient volume. On the risk pool, again, we're 6% behind the target. Some of that is the delay in payments and the rates that we're seeing. And then some other revenues, again, our grants and intercities, the timing of that has impacted our performance for Q1. Next slide. The expenses, we're also 1% behind. We're continuing to right-size our budget. We've done a great effort to do that in FY26, and that work continues through the year. In PS, the overtime areas that we're working on with different leads throughout the system and with our facilities include environmental, facility support, and nursing services. And in this first quarter, we had an all-hands-on-deck meeting with our CEOs, our OFD or facilities development leadership, and our group to come together and draw on the success that we saw in our temp all-hands-on-deck activities to further refine the process that we have to align with overtime use and establish models and assess project needs. So that work is ongoing. And on on a positive note, we're seeing a surplus in our temps category. We've drawn on, again, on the success that we've had with facilities to reduce our reliance on temps, and we're seeing the impact of that, achieving our alignment with the staffing models and doing a small surplus there that we're very proud of. On the discretionary spend, variance drivers include the timing of cash payments to reduce our outstanding payables. So we are paying our vendors faster or at a faster rate. We're working with our accounts payable teams, and they're setting up different processes to get the payments out faster. We're seeing the impact of that in our cash. But we're also seeing costs associated with infrastructure, medical supplies, and inflation. Of course, prices are higher for the same kinds of expenses. But the surplus in temps does help to offset some of this discretionary spending that we're seeing in Q1. And here we're seeing the purple chart to show our year-over-year performance. Again, that $40 million net difference we're seeing is slightly due to the impact of the discharges and the timing of the cash. We did have a lot of cash come in FY25 at the same time due to the recoupment of the CHC payment, the delays that we had in CHC, the Change Healthcare interruption that we're not seeing this year, of course. And compared to the budget, we are behind by 1% as the initiative comes up. And we're seeing in the charts here, the risk pools were slightly behind our targets. We did receive a lot more in FY25. We expected 26 would be less. So we did budget for that, but we missed that mark by about $7 million. Outpatient, the middle chart there, we're seeing that we received a little bit more in the outpatient. So that's, a good view there, but we're still working on inpatient to improve on the initiatives where we can.
Thank you. I'll pause. Any questions on the revenue side? I would just remark that we've been accustomed to meeting after meeting, we exceed our target. So I do understand, but it is a modest amount, less than 1%. And clearly you guys have done a good job of identifying where the differences are. And a lot of it is timing. So we expect to catch up. On the expense side, the focus group on the overtime, et cetera. So getting that under control. So I think I feel comfortable that, and the only question I have, it does sound much of and obviously Mitch's comment on inpatient versus outpatient, but the lower than anticipated per member per month rates, and I don't know, you're going to talk about this, Megan, later. Is that something that you think is continuing, or is that just a blip in time?
I don't think it's a blip.
Okay.
I do think that will be an ongoing concern.
Okay. And we had worked that into some of our forecasts and
Yes.
projections. And so does this mean that it's actually worse than we expected, or?
I don't think it's worse than we expected. I think the change with the essential plan premiums that John spoke about before, that was unexpected.
Yeah.
So I think that creates immediate pressure in the short term to figure out what's going to happen. And then I think the larger federal disruptions that make the premium more vulnerable, that to me is an ongoing concern, right? So, so I think we'll have to maybe try with more intention to try to mitigate some of those losses. And there's a slide later
Okay.
with some strategies there, but
Right.
I do think it's precarious for us,
Yeah.
but I don't think it's worse than what we had anticipated in the
Okay.
budget.
And the change in rates, is that already showing up here in this first quarter?
No.
No, so that'll be a future impact.
Yeah.
Thank you. So we'll get to that, I think, coming up soon. Margie?
So there are some, and it was alluded to on the managing risk slide, some upcoming legislative changes that are creating challenges for our patient population in obtaining and retaining insurance coverage. And we're particularly focused on these financial counseling initiatives to ensure that we can help patients to, while we comply with these changes and adjust our processes to accommodate them, we do anticipate requiring additional resources. Specifically, some of these changes are work requirements for Medicaid recipients, twice annual Medicaid redeterminations, and along with that, virtually no automatic renewals, the expiration of the ACH subsidies and the changes to the essential plan, data sharing with ICE, which is a relatively newer concern, as well as changes to the public charge rule. So in order to comply with these changes, we're anticipating an additional greater than 400,000 financial counseling interactions on an annual basis, which is just a huge number.
That's 420,000 more than we've
Yeah.
been doing
Yep.
already.
Yes.
What do we do annually, Jen? Oh,
Probably close to 1 million.
Yeah, it's about 1 million, right?
so it's a lot more.
Yeah.
It's like a third,
This is
yeah.
the 6 month, right?
Because of the, we're doubling the
I see,
redetermination.
twice a year, right,
Right.
year. Mhm.
As well as anticipating an increase in uninsured people requiring financial counseling.
Right.
There's a little bit of that built in as well. So Allison will walk us through some of the activities that are ongoing in order to prepare us for this.
Yeah, so we're really looking to implement a number of different strategies to try to address the challenges that Margie was describing. All of these are really meant to build off our existing financial counseling workflows, which have improved significantly over time and do continue to demonstrate strong results. Our current areas of focus are really first improving our pre-service financial counseling rates, really looking to strive to more often than not complete the process of financial counseling for patients who are receiving scheduled services before receiving those services. Looking to coordinate our strategies with our payer partners to ensure success. We're really looking to build off the collaboration that we put in place with both MetroPlus and Health First and our other big payers, which is particularly critical as we move towards those 6-month recertification requirements, ensuring that our outreach is coordinated in helping, our patients and their members maintain coverage. Looking to pursue some additional automation opportunities to supplement our financial counseling workflow. So we do think that artificial intelligence, for example, can help support some of the more routine financial counseling activities like information gathering and documentation gathering to allow our financial counselors to really focus on the more complex aspects of the interactions, including submitting applications and supporting our patients through the process. And then lastly, trying to just increase opportunities for patient self-service, particularly for patients who are interested in being able to submit their application or their renewal on their own. And we believe through really a combination of these strategies, we can try to mitigate, again, the challenges that are in front of us to help our patients maintain their coverage without the need for as much additional resources.
Thank you. Very challenging.
Okay, so as we've covered here, we have seen year over year that we're down about $7 million in our risk pool surplus performance. So the chart on the left is showing you a breakdown of the different insurance products that patients have that are attributed to our risk pools. So you can see that Medicaid and Essential Plan, which are in the first two rows, account for over 80% of the lives that are in our risk pool. So obviously the performance of those plans dictates a lot of our financial performance. So you can see here that in the per member surplus, that Medicaid is running negative. And that is about $7 per member per month worse than it was at this time in 2024. The 2024 is that we have a lag, so that the 2024 performance is what hits in our fiscal year 25 budget. So that's just to try to explain the numbers there. So on the whole, Medicaid is driving a deficit in our risk pool. So we are losing money on our Medicaid line of business. On the Essential Plan line, which is about a quarter of our overall members, you can see it's still running a positive margin, but of note, it's performing about $50 per member per month worse than it was this time last year. So we think that a large part of the driver there is just truly an increase in spend. So this is looking at Essential Plans still being a pretty high premium, but we have just a lot of spending. And I think of note, the Essential Plan 5 that John mentioned is going to be going away in July. That is specifically for individuals who make between 200 and 250% of the federal poverty level. And I think the expectation is that many of those folks may have foregone care. And so now that they have insurance, which they were eligible to start getting insurance in 2024, that has driven up a lot of spend. And so it remains to be seen what happens once they lose coverage. They might be trying to get as much as many services as possible in this interim period. And then they are expected to be uninsured, potentially starting July 1st. So the good news story here is that there are some products here that are smaller, right? That fewer of our patients might have, but by being at risk for them, they are driving a positive margin. And we've seen better performance year over year in our Medicare line of business and our commercial line of business. So that kind of segues into the next slide in talking about how do we mitigate some of this performance. So trying to get the right member and the right product is really, really important. And so if we have patients that are currently in mainstream Medicaid, but they qualify for a special needs plan, we can get significantly larger premium dollars to compensate for the care that they have, so that we're not running a deficit on them. Same case for Medicare, that if there are patients that need long-term care services, that might be a high cost spend category, we can get them into a better product that will give them more opportunities for more services, but also cover it with a higher premium. So there's a lot of work underway that we're partnering with financial counseling and trying to figure out, as we're having conversations about what insurance someone might be eligible for, that we're connecting them to the right product. There's also an opportunity for us to work on truly capturing at the point of care all the diagnoses that a patient has, so that gets properly reflected on the claims that the insurance companies pay, that then impact how their actuaries set premium in the future. So that's also a focus for us. And then the last point here is that we do have outreach programs where we're trying to call telephonically members who have been hospitalized and trying to get them in follow-up care, so that we can prevent any type of readmissions that is going to drive up the spend. So that's a snapshot of 3 different things that we're doing.
We had been doing a lot of work before on improving our capture of risk and diagnosis.
Yes. And one positive note I can say is that despite this recent Essential Plan premium, so the premiums were lowered starting January 1st, 2026, Metro Plus actually is going to see more premium revenue because of risk adjustment. So their risk
But
attributed.
despite the rates going down.
Right, it's offset by a significant increase in their risk performance. So that's a real life example of how we can try to mitigate some of these things.
That's pretty significant.
Yeah,
Right, I mean, the dollar value is over 100 million or
Right.
something like that. I mean, it's phenomenal.
Right.
really.
and that's for across all the different plans, Medicaid, essential plan, doesn't,
The strategies are
the
across all the
strategy,
plans,
right?
yeah.
Mhm.
But I will say that the chart that we had up there before. It's
Plans.
Yeah, it's the same profile across all of Health First and all of Metro Plus. They're all kind of seeing that same margin by type of plan. That Medicaid's losing money, essential plans, has a positive $75 PMPM. So it's not just us. I think actually ours is a little bit mitigated versus Health First and Metro Plus overall. But it does make the point, like if the Medicaid rate should come up a little bit, and the essential plan could come down, but that balance is important because you can see that for the most part, we are losing $2 PMPM for every Medicaid patient we serve.
But John, isn't that because the state only pays 10% of the essential plan and 50% of the Medicaid?
Yes, I mean, they're trying to make their global cap.
Right,
budget
they're just making one as low as possible and one as high as possible
Yeah.
in hopes that it equalizes, but that their share is smaller.
True, and I know people that have done exactly that in their career. But you got to find right? You got to still find that right balance. Because
Right. Yes.
I'm talking the other side of myself.
Right.
So again, it's.
They may not have the balance right, is what you're
Yes.
saying.
Yes, it's
But
just a little tweak.
It exists for a reason.
Yeah.
It's not irrational
Yep.
that Medicaid is low and the essential plan is high.
Correct.
But that with a lot of people on Medicaid will remain eligible, they may or may not be able to fill out the paperwork. People on the essential plan may not be eligible, right? And they'll just fall off
Yeah,
and
yeah,
become,
Yeah.
Uninsured people,
yes.
right? So it's a very different
A
thing.
lot of dynamics at play. Yeah.
But the impact for us is more severe because we have higher Medicaid population or?
Well, I mean, it's yeah, I mean, in some ways, yes, but it's all kind of working off a base that we have already established, right? So if we were making $7 PMPM on Medicaid and now we're losing $2, right? It's that difference that got factored into the lower risk pool, right? And we'd like to get, again, we'd like to advocate for, a better balance. And the state has an obligation, the actuary has an obligation to set a rate that is actuarially sound. And I think part of at least this indicates is that, maybe it has to come up a little bit.
Mhm.
So, but
That
we'll
makes
keep
sense.
working with that. I think the other thing to point out, and Megan, is that whenever we move somebody from Medicaid right down to special needs plan, which is the right person, right plan, right program, you can see you go from losing $2 to making $900.
Oh,
Right.
wow.
And they've done a real nice job, right? And it's a better program for those people that are special needs eligible, right? Because the program is really tailored
Designed for them, yeah.
Yeah. So we're doing a good job there. I think but
Right.
we could do more.
And we heard Metro Plus is the #1 special needs HIV plan in the whole state,
Yes.
right? So that's part of why the amount is so great, because you're getting incentivized because of how well our performance is.
Yes. And the homeless, I think, qualify for that, right? For the-
Yes.
Yeah. So the movement of homeless patients into the HIV
Special
program is beneficial.
Excellent.
Yeah, so these opportunities are, you're laser focused on. It seems that there could be good opportunity there to help navigate this landscape. So, thank you.
You got to keep digging.
Yeah. Well, great. Thank you very much for that update. And we look forward to hearing how things continue with all of the risks that you identified. Again, despite the miss, I think it's very good report on terms of what you guys are working on. So thank you. Is there any old business or new business from committee members to bring before the committee? There being no further discussion, the meeting's adjourned.